Hey, hello, everyone. I just realized my light fell. We need the pretty light this morning. All right. Hey, everyone. I'm so excited to see you. So we're back. We haven't had an Ask the Experts with us two in a while. We've been doing our lunch and learns, which obviously we love. We love bringing you special topics, specifically topics that you all request. That's usually how we pick which lunch and learn we're going to do. But I always like to ask the experts. So the feedback that I get on social media and private messages is always that you enjoy it the most and just appreciate that resource to have a place to kind of ask your questions and get resources and information. So, to meet your two hosts. So Liz McInvale is on my screen, you're to my right, but
here I am, wherever I
don't. Yeah, that way. So Liz is an incredible advocate. She's been one of the faces of the IOCDF for a long time and well-deserved. She has brought inspiration, hope to so many, myself included. But we're doing a talk at the conference, and I got to see her record it yesterday. And she makes a really good point. She's an advocate, but she's also a clinician, and she's been amazing in both spaces. And I think that being a clinician with OCD always is such a special place. I think clients really, really appreciate that. So Liz is coming from both an advocate and, of course, a clinician lens, and she's here today to help answer all your questions. And I'm Chris Tronson, and I enjoy seeing you as well. I'm both an advocate and a clinician. So today on Ask the Experts, it's all about you. We did get pre-submitted questions. I need to record a mailbag. I know Liz has done one, so that is definitely on my agenda for this weekend. So if we don't get to some of the questions, we've been recording them and putting them on our YouTube channel. So make sure to go to our YouTube channel, which is just youtube.com/IOCDF to see some of your questions answered. Skyla has been doing amazing with having timestamps so you can even see what specific questions are being asked. But we are going to get to as many questions, both live and submitted, as possible. So we'll jump in, but really quick, just a few quick announcements that we're required to do. Of course, we want to remind you that this is for educational and is not intended to replace therapy purposes, meaning that you should be seeing somebody who is specializing in OCD and related disorders who can really work one-on-one with you, but we're here to give you education resources. If you have treatment-related questions, please work with a provider or contact your local clinician. One of the best things in the way that I found my therapy was to go to the IOCDF's online resource directory at iocdf.org/find-help. Also, a suggestion I always make is when you find a few, go to the website, vet them, or reach out to the IOCDF or your local affiliate to get some direction if you find a lot of people and you're confused which one to work with. The IOCDF is not a crisis hotline. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911 or the 988 Suicide and Crisis Lifeline. By dialing 988, you can also access online at www.988lifeline.org. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support each other. A note that this is being broadcast on several social media platforms and is being recorded. I'll talk a little bit more about the announcements and everything at closing, but one reminder, next week, starting this Sunday, is Ocd Awareness Week. So there's going to be a lot of amazing programming here at the IOCDF, both virtual and local. To find that out, there's a calendar. So I always just Google iocdf.org and calendar. I'm sure there's a better link to that. And that way you can see all the live streams, all the different educational and interactive events the IOCDF is having. And of course, any local affiliates or local organizations that are doing stuff for that. So awesome.
Let's hop in. Chris, it's so good to see you. And I want to just caveat really quick that Chris is also an incredible advocate and clinician. And yesterday when we were doing our talk, we were really talking a lot about just the different things we've been through as advocates and clinicians and how we wear both hats. And so when we come to you and are answering questions, we're really trying to answer them from the professional hat. But it would be silly for us to say our lived experience don't also impact that, right? I think that sometimes when we're talking about treatment or new things, right, Chris and I are so strict about sticking with evidence-based interventions and really sticking with what we know the research shows us works. Because what we've learned is that individually it makes the biggest difference, but it's also what is the best clinical approach. And I say that just because, Chris, I want to kind of continue our conversation we had with John Abramowitz a couple weeks ago. That's actually, he's going to be coming back on at the end of this month, which I'm really excited about. We're going to do our part 2, where we talked a lot about, because I almost find I'm looking through the million questions we have on Ask the Experts. Chris said we have a couple, we've got a billion.
We have a lot. I always say a couple.
Right, almost all of them are about treatment, right? The questions are like nuanced treatment questions. How do I know it's the right treatment? How do I not? I want you to follow the research, the evidence, and the science. And I really want you to know that the reason we do that is that there is known interventions for OCD that have been studied with rigor, have been tested, retested, tried over and over again, that really allow us to say this is the best intervention to do first. That doesn't mean that's the only intervention you should be doing. Right? We talked a lot, we've talked in previous live streams, that if you have a comorbid diagnosis, if you're dealing with something else, if you're struggling with general anxiety, maybe anger issues, right? We should be adding in other methods of treatment. We're not going to do ERP for OCD and do ERP for PTSD and do ERP for, personality stuff. We're going to figure out what is the evidence-based intervention for that diagnosis. And so treatment should always be tailored. But at the end of the day, what we want to continue to send is a message that help is available, that you can recover from OCD, you can live a full life, and that the best way to do that is with evidence-based approaches. And we know that ERP should be done individually, it should be done specifically. It offers the best chance at treatment remission. That doesn't mean ERP alone is, Chris, I'm going to do ERP with you and you're going to get better. The work comes from us, from those of us that are struggling, right? The output is about the input. So you are going to see the rewards and the benefits based on how much you're willing to do the work and you're able to. And sometimes what we find is that we need to make some medication adjustments or do some other treatment first, because that might be more useful versus ERP in that moment if we're not ready for ERP. But at the end of the day, Chris and I are speaking from personal and professional more important. That's the hat we wear on Ask the Experts. And we are saying that ERP is life-changing, life-saving, and works so incredibly for a majority of people with OCD. And so let's hop into questions, and you're going to find us continuing to reiterate ERP. That is why. Number one, how do you handle an adult child with OCD that's violent? They cannot live independently on their own, and you cannot kick them out of the house. This is something we hear a lot about. And so the question at the end of the day is, how do you manage treatment for your adult child when they're the ones that need to make the decisions, but you're seeing it be their OCD or their other symptoms become disruptive?
Yeah, one thing that we learn in all of our training, I always remember this from graduate school, is that crisis overcomes everything. So if you put a client who's violent with OCD and is being violent in the household, and you try to force them to do treatment, if they're not on board for treatment, and if they're not ready to handle the emotional dysregulation that comes with facing our fears, most likely, if they don't have any healthy coping skills, they may become more violent. So the first and foremost thing you want to do is make sure that the client wants to be in therapy. So there's a really good study that I always refer to. There's a style of, I don't know, it's not necessarily a treatment modality, but it's a treatment tool called Motivational Interviewing. It originally came for like gambling and alcohol and drugs, but it's really to get a client to see the value in being in treatment. And there's a great study on using that for OCD. So if I was to work with a client who is reporting being violent, I first want to make sure that they see value in treatment and want to come in. I also want to make sure to get the family involved, make sure that we have like a safety plan, et cetera. There's a type of treatment, dialectical behavioral therapy. So that's not evidence-based for OCD. It is evidence-based for emotional dysregulation, for self-harm, for suicide, et cetera. So working on giving the clients, this client particularly, some skills so that they can self-soothe, so they can calm down, so they can get out of kind of like that cycle of violence. I will say a lot of times I was violent. My mom, sister, and I have been very candid in our talks. I was very violent in high school. Part of it is because I had a disorder that was undiagnosed and untreated. So sometimes all the advice I just gave you might not be necessary. Sometimes it's getting them into a provider who can say, look, your outbursts are coming from frustration because you don't have evidence-based tools. Here's what I'm going to be able to give you, and the treatment works. Maybe starting them in a support group so that they can see they're not alone if that's their frustration. And also, a good clinician isn't going to jump into exposures day one. They're going to give a lot of psychoeducation to this client so they understand why they're so frustrated. So there's a lot of steps that you can take. Lastly, what I'll say, if you do all that and this client is still violent, it may be coming from other sources. You want to kind of assess why they're so angry. But at the end of the day, your family and loved ones' safety is most important. So you have to get other people involved, whether it's the police, whether it's the police you wouldn't want to go to first. There's different mental health teams that are in your county. You just have to find out resources to maybe step in and to help to make sure to protect your family. But that's always important, especially if you have other children in the home.
Yeah, I want to hop in with 2 more quick tidbits. Number 1, definitely consider the space training by Eli Leibovitz. This is a training that is specific for parents and how to support and how to kind of set boundaries that can be really great. So this is a treatment that you go to as the parents, but you don't necessarily have to have your child go to. The second is Chris has an incredible family support group through OCD SoCal that I highly recommend. This is a great question that I want to set back on, because I think Chris gave great ways to intervene from a treatment perspective and what we would hope for the patient treatment wise. But as the parent, it is okay. And in fact, I would encourage that you have boundaries around what you allow and don't allow in your home. For example, you don't have to allow your child to be violent. And you can have rules around, if you live in our home, these are requirements, these are boundaries, these are expectations. I get this question a lot from teenage and younger children around younger children is like, well, they slam the door or they cuss and we let it slide because they're struggling, but like we wouldn't. And I always say, well, would you let your other kid do that? Well, absolutely not. Then we shouldn't let the child with OCD do it either. We do not allow OCD to be an excuse for other behavior, because guess what? We're going to have jobs one day, I hope, and we're going to be independent, and we have to learn how to manage our distress in ways that doesn't have these really big outbursts. And if they're not able to do that, we need to approach that in treatment. And that might be with things like dialectical behavioral therapy and other interventions that can focus much more on emotion dysregulation and distress.
I just want to add really quick. I think the biggest thing I hope you just heard Liz say is, please just don't let it be the homeostasis of your family, and just let it be. There's absolutely help.
Yeah, 100%. Next question is, how can we support our adult children with OCD when they become discouraged or showing moments of discomfort and they cry because they're stuck in compulsions? This is a really good question, and I'll give my quick answer, and then Chris, you hop in.
You go first, of course.
OCD treatment is really hard. We expect and anticipate that there are going to be moments of discomfort, that your child is going to cry, that they are going to pull you in ways that as a parent, you want to fix it, you want to correct it. But it's, what are we teaching anxiety and what are we teaching OCD? We're trying to get our child, and as parents, we're trying to teach them how to change their relationship with OCD and anxiety. And so when they're feeling really anxious and when they're really struggling, you can support them and you can offer healthy support, but we don't want you to give in to OCD. We want to be able to ride the wave, because again, if we respond with anxiety and we want to fix the discomfort, we're sending the message that anxiety and discomfort is dangerous. And the message we're trying to send is actually that, like, you can tolerate it, right? And that you can still do the things that are important despite this distress that you're feeling, or the messages of distress that OCD is sending to you.
Yeah, I mean, Liz answered this perfectly. So what I'll just say is, what happens when somebody has OCD is the whole part of their brain that thinks that they're in danger and that they could be a harm to themselves and others activated. So we give into those compulsions because nobody wants that. Nobody wants to be hurt. Nobody wants to hurt others. So what ends up happening is, when you're in the treatment and you're really learning what's going on in the brain and you're making changes both mentally and behaviorally and not giving into that, it feels like you're being irresponsible and you're letting yourself do things that are against your values and that are harmful. Quickly, someone working with a good therapist will learn that actually by giving these things up, their life starts to open up and be free. So the best thing you can do is, just like you supported your child in doing their homework growing up, you didn't do it for them. You didn't yell and scream at them for doing it. You were just there to be supportive. Definitely, that's kind of your role, but let the therapist be the therapist.
Next question is, sorry, I'm seeing some of the live questions too and trying to debate, but let's hop into this one because it's the same about a parent. So my son was diagnosed with OCD at 18. He went on meds right away and ended up having an awful experience, a psychotic break. He went off the meds and has zero trust in the medical establishment and is reluctant to embark on the therapy journey as well. What's the best way for me as a parent to support him and continue to encourage him to seek help? This is a really good question because, Chris, we get this all the time where a lot of patients with OCD get really bad care, get improper care. Sometimes they end up at psychiatric hospitals that make them worse or make their symptoms worse, and they start to lose trust in the therapy system, the medical establishment, and helping professionals. So how do we reestablish trust in our system?
Yeah, I would say first, I always remind clients, because this happens a lot, that psychiatry and psychology are two different fields. And so when somebody comes and works with a provider, and I mean, Liz just hit on the nail, it has to be somebody trained. That's why the BTTI is happening. That's why, there's other organizations that are doing evidence-based trainings. So a lot of times if somebody comes in and had a bad medication experience, I explain to them, I'm not a psychiatrist. My job here isn't to convince you or push medication. I'm going to really work on the behavioral treatment. And if you do it correctly and you do it in a systematic way, there aren't the same side effects that you may have with the medication. The other thing is, I know a lot of clients that had poor experiences with psychiatrists. It's usually a psychiatrist that doesn't really know OCD. When a client comes in and talks about like, hey, I'm having intrusive thoughts, I've had a lot of clients get misdiagnosed with a psychotic disorder. They get put on medication more so for somebody with schizophrenia or psychosis. And those medications can be harsh. And then the person's OCD is worse, or a client has ADHD and gets on a stimulant, but was never explained that could elevate the anxiety. And so what I do and what we do at our clinic, and I know Liz would do it as well, is we have a set of referrals, or at least we engage with the client and give them some expectations of what a psychiatrist should know. I always refer, there's a great Dr. Jenny Key article on the IOCF website that gives guidelines. Lastly, what I'll say in general is if I have a client that was really resistant because of poor treatment in the past, I'm all ears. Let's talk about it. I want to hear from you about your experience so that we could see what they did that I don't agree with. Because a lot of times clients will open up about what they went through that wasn't helpful. And when I explain what ERP really is and what we're actually going to be doing together, maybe I'll link them up with our support group so they can hear that other peers have been doing it and getting better. Well, a lot of times when clients understand that the treatment for OCD is much different than the treatment they've received in the past, they might be more willing. And then moving at the pace and meeting the client where they're at.
100%. Remember too that it's about rebuilding that trust. And I believe that organizations like IOCDF being able to listen to advocates can help with that, just because you can start to see that, oh, there are individuals with OCD who have gotten better. And then you start to believe that could be me, and you might even be willing to give treatment and things a chance again, right? Which is really important, is to kind of put some real life examples that we had bad experiences and we can still get better. I think Ethan's keynote that's recorded does a great job of displaying that as well, that I'd recommend.
Liz is going to hate me because I'm going to cut her off real quick, but I do want to say something, because this is going to shout Liz out. I went to the IOCF conference and saw Liz speak live, and I always get emotional about this because it was life-changing for me. When I saw somebody my same age get through this treatment and get better, it renewed my hope. And when I went back to treatment, I was completely in a different mindset. Not to shout myself out, so I'm not going to talk about myself, but I'm going to talk about the 5 amazing advocates that I recorded a presentation with. Have your loved one go to the virtual conference, watch our talk on advocacy, because I just heard 5 amazing human beings speak about the triumph that they went through, including Liz. And so please, please, please have your loved one access real stories of people getting better, because it was life-changing for me, and I think it'll be life-changing for you. Your son.
Yeah, I always talk about the fact that I think that our treatment journey starts with advocacy, where we meet someone else, and when we see that other people can do this, or that I'm not alone, we start to have a little bit more fight in us. And then we fight, we do treatment. And then I also believe that our treatment journey ends with going back to advocacy and being able to help other people. And to me, that's the full circle of treatment. It isn't just ERP, which is in the middle. The next question is, I'm in a PHP program that I don't think I need. What should I do? I'll answer this quickly because I run a PHP program. If you don't think you need it, you should be talking to your clinician. First of all, if you have OCD, we want you to be in an OCD specific treatment program, not a general one, because oftentimes it will be like, this doesn't appeal to me, or I don't really relate to this. So the PHP program should feel right for you. There should be clear goals, and you should be communicating with your providers. Nobody should ever be seeing a provider and feeling like this isn't the right treatment, or I don't know if I need this, and not feel comfortable talking to them about it and really being able to weigh out your options. You should absolutely be talking about that. In fact, you guys, my therapist this morning was like, Liz, I think it's time we go back to twice a month. You don't really need weekly sessions anymore. You're doing good. We're not, because oftentimes we haven't been doing a lot of OCD work in a while. We've been doing more of family dynamics and other stuff, but even that we've worked a lot through. And she's like, I just don't think we need weekly. It is our job as clinicians to be talking with you about what we think you need, what you don't need. And so you should be able to talk to your providers about it. But if you don't think you need it, your treatment isn't working well, or it's not giving you the results you want, or you don't think you should absolutely be listening to that and be talking about it. Next question, Chris. After tackling all the items on your hierarchy list, is it unusual to need ongoing counseling?
You know what? One of the biggest mistakes I made, so please don't do this, is once I tackled everything on my hierarchy, I stopped treatment. Part of it was because my family just didn't have the finances. And the second was it was about a 2 to 4 hour, I don't know why I said two. It was 2 hours each way. So a 4 hour round trip for treatment. So it just was too much of a toll. I wish I did. And what I would say is that once you've tackled everything on your hierarchy, the next step is to really focus on potential things that are going to come up. I had been housebound, so now getting a job and all these different things came up. So you want to spend a little bit of time definitely focusing on the things that you can get up. But I think remember is like the therapist wants to treat you as a whole person. So getting you back into the activities you love and value. And then you want to kind of keep, just like Liz said, if you're going through an IOP or a PHP or you're doing treatment 3 times a week, you can definitely taper down, but I would hesitate to drop off treatment as soon as you hit your hierarchy, because inevitably things will come up. I will say what I do with clients is I let them take more of the directive role. So what would you like to talk about today? What would you like to work on? If they're at a really good point. But I would say if you just finished, it would be better to taper those sessions down versus eliminate completely until you and your clinician decide like, hey, we're staring at each other for the 50 minutes. I have nothing to talk about. Maybe it's time to go to check-ins every 3 months or something like that.
My new soapbox, because y'all know I can't not share my thoughts around things. So my new soapbox is, what should you expect from weekly treatment? If you are going to treatment every week and we're talking about the triggers from the week and we're setting exposures and that's what we're focused on, that's okay in the midst of like active ERP treatment. But that is not what treatment should look like forever. We should not every week be dealing with the crisis of our OCD from the week. We should be talking about our core fears and approaching them and how we're changing our relationship with anxiety across the board. But it shouldn't be, oh my gosh, here's the intensity, here's the triggers, this is what I'm doing. And so if it feels like, okay, I just worked through those triggers and I'm done with treatment, I actually want us to take a step back and say, what did we learn from treatment? What have we learned about how in our life every day we're going to approach our anxiety, we're going to approach OCD if it tries to throw something new at me. So it actually isn't about, did we work through our hierarchy and did we check things off? It's, do we know how to approach our fear when it tries to throw something new at us in the future? Do we know the behaviors or all the things that we do that actually reinforce our OCD and anxiety? And can we be aware of that, right? So treatment isn't really about just reducing our OCD symptoms. Yes, that's critical, and that will happen as a part of the treatment process. But treatment is about, have we learned how to change our relationship with OCD and anxiety? And do we know what that will look like in the future? Do we have a clear understanding of how I'll be able to continue to do that and live my life as that, right? So I want you to think about, yeah, maybe you made it through your hierarchy list, maybe not. But also, what have you learned from treatment about the way you're going to live your life, about the way you're going to approach when certainty is trying to pull you in, or when you get stuck with an OCD trigger or anxiety, right? It's the bigger message, the bigger understanding of what treatment should teach us across the board versus knocking out specific triggers. Let's jump to live questions, Chris, because I think we've gotten some here that I want to make sure that we go to. So the first question from Mike at 11:15 is, what would you recommend for an older parent who thinks they have OCD or scrupulosity?
Yeah, what I always say when somebody wants to approach someone, when you think they have OCD, I always say, what is their medium of accumulating news? Do they like podcasts? Do they like newspapers? Do they have art? Do they like articles? Is there a specific source that they get a lot of information from or enjoy? So if I had a family member that I thought was struggling, an older parent with OCD scrupulosity, what I'd probably say is that sometimes, I don't want to stereotype, but sometimes people that are older, your parent, don't always take that kind of advice well from a child, because it's like, hey, I'm the parent. But approach your parent like you'd approach them for anything else, and bring material. The IOCDF.org is an absolute gold mine of resources. There's plenty of resources on OCD. So on scrupulosity rather. So what I would do is I'd visit the IOCDF website. I would find information on scrupulosity, and then I would find the way he consumes his information. If he's a podcast guy, there's plenty. I know Kevin Foss out here in Orange County has done plenty of podcasts on scrupulosity. I know there's others, so I would first and foremost do that. If he's more of an article, I would find articles on the website. And what you can do is do a soft approach to see how he responds and just say, hey, I know you're a man of faith, and I'm not questioning that. And I'm not saying that you need to abandon your faith, but there's certain things that I'm getting a little bit worried because it's causing distress in your life. Here's some resources I found. Why don't you just take a look at them and let me know what you think? A lot of times too, what I'll do is I'll involve that person's priest or practitioner, because a lot of times that person is convinced that this is about faith. And sometimes 1 or 2 meetings, not a reassurance session, but 1 or 2 meetings with their religious figure, correct, sometimes can help them get clarity like, hey, this is OCD and not. So I have clients that will be praying 3 to 5 hours a day, saying that this is what's required of them. We'll meet with their pastor once, and the pastor's like, I don't even do that. And so at least the client shifts over to recognizing it's OCD.
Right. And it allows you to have a rule book for kind of like, what are our goals, right? Again, OCD treatment shouldn't be that I get you to my values or I get you comfortable with the way I live my life. It should be getting you to your values and getting you to where you want to live your life versus OCD making those decisions. And I can't say that for you. You have to be able to say it for yourself. But sometimes we need some like guidance of trusted individuals in your faith practice to help you say, okay, but oftentimes you'll also find that people with scrupulosity will say things like, I know this is out of the norm. If I didn't have anxiety or OCD, this is what my prayers would look like. This is what my faith practice would look like. And so it's like, okay, then that's what we're fighting to get you back to. I'll answer a question quickly from Mark at 11:15. Do you have any advice on how to treat OCD merged with narcissism? So I really think that this is going to be with a specific provider, right? So we really want to tease apart where is OCD versus potentially some personality stuff. Are they like, is this OCD? Is it not? What's the differences? And so there can be a specific treatment plan. But treatment would certainly look a little bit different if we're treating OCD versus we're treating OCD comorbid with other things. And that's where we want to know what is the best treatment to do for that. 11:23. What do you feel? Chris, you left me.
No, I don't know what happened.
What do you do if part of your illness is an intense fear of drugs and medications and you're too ill to do ERP without them, or so you've been told? Great question. So what do you do when OCD is attacking taking medication? And it sounds like it would be it's important, or this person would like to consider taking medication. So let's assume that's the case. Because again, if you don't want to, that's different. But if you want to, but OCD is stopping you, what do you do?
Yeah, I mean, that would be where I would work with a client. So if the client and I were working together and that they, like, let's say a psychiatrist had evaluated them and said, hey, you really need medication. Or let's say I was working with you, the way that I tend to bring up the medication conversation with a client is if they're doing everything right, we've gone to the right level of care, whether they've been in a residential or PHP, IOP, or multiple sessions a week. So let's say that's not the issue. Let's say they really want to do the work, et cetera. And ultimately, the only thing stopping them is needing medication. The first thing is, I was the same way. My OCD was all around taking my medication, having to touch something and put it in my body. I have BDD, and so it was like, can this medication alter your face? The thing that I often find helps is first and foremost referring you to a psychiatrist that understands OCD and is going to be patient and is going to work through that fear with you. And then in session, in tandem with the other provider, I would have us create a mini hierarchy around medication and work on that together. Because remember, the goal of treatment is to be able to do anything that you want to do without the OCD stopping it. So this isn't a threat, don't let no therapist should be threatening and say, I'm not going to work with you if you don't take medication. That's not our job. Our job is to work with you where you're at and to move at that slow pace. But getting a psychiatrist that understands OCD involved and working in tandem is absolutely important. That's probably where I'd start on this one.
Totally. Next question that we had is, when I'm busy, sometimes I have a hard time fitting in exposure therapy. It's easier just to not do it, even though I know I should. What advice do you have for setting realistic goals that are attainable?
Yeah. Do you want to take that one first and then I'll kind of add on to it?
Yeah, I'm happy to. So I think this is about, Sarah, living life, right? More than doing exposures. So I want us to focus less on like, are we setting in time to do specific ERP and exposures? And instead to think about, are there things we're avoiding or things we're struggling to approach? And if so, can we start doing it, right? Can we start approaching? Can we start living, right? That's the goal of treatment, because if we start living and approaching, we're doing exposures, right? But we're doing them by just living our values-based life. And so I want us to focus on what are we avoiding. Now, there's a question that I throw in there, right? Or a statement I'll say is when it says it's easier to just not do it. That tells me there is avoidance. And so I want you to say, where is the avoidance that's making me say, oh, it's easier to not do it? and let's start approaching?
First of all, thank you for watching all the time. I would say the big thing that I do if I'm working with a client who is super busy, because I'll have clients that are new parents, plus they're working and all that, is what I do is if there's any exposure that's going to have to remove you from your everyday life. So let's say your OCD is around driving and you'd have to kind of get in the car and drive for 45 minutes or something. I might not focus on that right away and figure out how to incorporate exposures into the life that you're already doing. So for instance, if you're leaving the house a lot, let's do exposures if your OCD is around checking before leaving. So what I'll do is try to incorporate exposures around your everyday life. And then the good thing is we're pulling lessons and learning from each exposure you do. Then we can kind of take that learning and make it universal. And so then it's less about the exposures and more kind of understanding what's going on, and then just incorporating that, resistance to giving it to any compulsions altogether. I always say this too, is doing compulsions is exhausting and time consuming. So you'll start to learn that doing the exposure and not avoidance is actually much more time efficient.
That's right. I'll let you hop to the
Yeah.
next questions.
Yeah. Nicholas says, hi, since the two don't often mix well. They're Eastern Orthodox and mental illness isn't accepted well into it. So how does someone, you're probably better to answer this. I grew up Greek Orthodox, but I know that you're more faith than I am. Like, how does somebody manage their faith if, it doesn't seem to fit with their mental health?
It's a good question, and it's tough. I think this is about, is there opportunities for us actually to bring education and to start to change the understanding of mental health in our faith practice, right? There are many faith practices that are starting to become accepting, but that doesn't mean even the ones that appear accepting, there's still a ton of stigma and a ton of work to do in the faith region or in the faith practice. So the first thing I would say is, can you be a spearhead to bringing education and insight to mental health into your faith and into your religion or your religious practices? The second is Katie O'Dunham, to give a shout out to, who's one of our lead advocates, leads an entire faith and OCD special interest group with IOCDF and does a ton of work and helps collaborate in this field around this specifically, is how do we better educate and create better support within all faith practices for mental health? And so I definitely want you to consider being a part of that and collaborating. The second piece is, how do we start to align, right, and understand values when values come in conflict and what it looks like, right? So if our faith is really important to us, can we still practice our faith, but also know that our particular faith practice might not be the place that we're going to get the support we need for our mental health? And so can we find that elsewhere, right? I want us to think about, how do we build an inclusive and large support system? There's some times where if I need support, I might call Chris or text Chris and get it from him, where other times I might get it from my husband and other times from Ethan or from other friends, right? And it's really about, what support can we get from those and how do we know what that looks like, right? Sometimes we aren't able to get the support we need for our mental health, but maybe we get the religious support we need from our faith, but for our mental health, we have to get it from other places. And so it's okay to build your group. So it's twofold, right? Protect yourself and figure out how you create your own healthy support system while living by your values. And could you be the person that helps bring education and change to your faith practice for OCD and mental health?
Well said. 1226, Skyla. Grace asks, the question's longer, so I'll kind of sum it up. I read through it. What happens if somebody only has time in their schedule to do once a week treatment? They have, a very busy schedule, and that's just not enough. What would you do if somebody's like, look, I just don't have in my schedule because of work, because of school, because of everything else, but can only make once a week, but feel like it's not enough if they're not making the progress they'd like to make?
Yeah. I love this question because my answer is going to be short and sweet. Treatment is every minute of every day. It doesn't matter if you go to a therapist for once a week for 45 minutes or if you can't go at all. Treatment and exposure should be how we live our life all the time. And so if you're busy and if you have a lot going on, great. You get to integrate exposures in life into everything you do, right? That's about, are we approaching anxiety? Are we approaching the things our OCD or anxiety want us to avoid every day, all the time? We don't have to make it where we're doing more treatment to mean we're doing more exposures. Chris and I do exposures every day, all day. We might not even have to call them exposures anymore because they don't even feel like it. It's living life, right? It's things we used to avoid. And so I don't think anyone needs intensive treatment forever. And we wouldn't want you to feel like that's a requirement. And if you're able to to engage in life, that's the exposures are built into that. If you find that you're doing all these things, but you're ritualizing and you're not able to do them the way you want to, that's when we want to get you that extra support and increased treatment so that you can be doing those things freely, right? I don't want you to be functioning with a high level of OCD. I want you to be enjoying life freely despite maybe your OCD diagnosis. And those are two different things.
And you'd be good to answer this one too, obviously. So at 12:32, additionally, how do you know when it's time to seek a higher level of treatment? So as a treatment center that offers higher level of care, when do you know, like, hey, this is a perfect fit for a client to come to a treatment program like this?
Yeah, I want us to think about two things. I want us to think about, number one, a big indicator is functioning, right? If we're starting to see that OCD is impacting our functioning, friends, family, life, career, sleeping, eating, et cetera, right? Then we want to consider treatment. If we are doing traditional treatment, right, at ERP with a good clinician, and our clinician is saying we might need to consider something more, that's really important, right? A clinician should be helping you evaluate if you need more at this time. The second piece is, are you not able to make the progress you want at the level of care you're getting, right? So if you're getting good OCD treatment once a week, but your progress is kind of minimal, or you're finding that, like, I'm not able to gain that traction, or what I talked about earlier is what's happening where, like, every week we're just dealing with our OCD triggers from the week versus actually being able to apply it and see growth, that's when we'd want to think about a higher level of care. There is no shame or stigma in needing a higher level of care more than once. I'm a perfect example. I went inpatient at 15, I went back at 17, right? And then I kind of had to navigate outpatient treatment and on and off at different levels of intensity until I really understood how treatment as a lifestyle looked for me. So I always want us to consider a higher level of care versus waiting. The second piece, though, and I actually was just talking to one of my clinicians about this the other day, when she's like, how do you know if someone is severe enough? And my answer is, like, why does someone have to be super severe to get intensive treatment? Why do we say you have to be at a level of total dysfunction before you come here? Like, no, if someone's like, hey, I'm struggling, but I'm still functioning. I think a lot of times people are like, oh, well, if you're still working and doing this, you probably don't need this level of care. But if as a patient, you're like, hey, I know I need more and I want to go to an intensive level of care to knock it out because I don't want this to drag on, and for me to do outpatient once a week for a prolonged period of time, if I feel like I can go get a condensed amount of treatment quickly and get back on my feet, then, like, great, you should be doing it too. So if you're questioning it, I think you should start seeking and considering it.
Well said. One of our Ask the Experts questions says, when do you know it's time to potentially switch therapists? It seems like other people getting treatment are getting better and I'm not making as much progress.
I want you to talk to your therapist about this. I want you to feel comfortable, saying something like, hey, Chris, we've been working together for about 12 sessions. And, I feel like I was hoping that I would have a lot more progress and I'm trying to figure out what's going on, and have a collaborative conversation. Chris might talk about how, like, yeah, I'm worried about that myself. I'm wondering if you need a higher level of care. Or he might say something like, Liz, I agree, but at the same time, we're not doing ERP yet. And you're holding on. And so going to a new clinician, if you're still going to hold on and not do ERP, isn't right. Sometimes absolutely it's the clinician. Sometimes it's, are we willing to do the work the clinician's asking us to do? And so sometimes it has nothing to do with the clinician. It's, are we ready? Are we willing? Right. And that also, though, is something important to talk to your clinician about, because maybe you need to change what you're doing. Let's quit trying to do exposures in ERP if you haven't bought into ERP yet. If you don't agree that this is what we should be doing, we need to slow down and do readiness work first. So I want you to think and talk about it with them.
Well said.
Chris, let me hop into questions for you.
Yeah, of course.
So one of the questions that we got at 11:36 is, I suspect OCD and other mental health diagnoses have a high level of ongoing mental stress that the brain needs more serotonin, dopamine, and other hormones that are chronically being depleted. The illness is causing a legitimate need for more specific hormones that the body can physiologically effectively reproduce on its own. So I guess I'll answer this quickly, and then Chris, you can too, but it sounds like maybe there's just questions about what OCD might do to our brain, the impact it might have on us. And I want you to talk about this with both your clinician and psychiatrist to figure out what your individual needs are. But we do know, right, that OCD is a disorder of the brain and that it does impact us in a lot of different ways.
Yeah, there's a lot of good stuff on the ISDF. I always, I'm a nerd, so I like to read different stuff and learn about different parts of the brain. And there's a lot of reasons that we think that individuals have OCD or how OCD affects the brain. And I would say like the biggest thing that I also want to kind of add to this conversation is that I think also sometimes what we forget when we're in treatment is to kind of focus on whole self as well. And so, you talked a lot about like the hormones and the chemicals and stuff like that. I do think sometimes, like if you are going through a lot of hormonal changes, I know a lot of people's OCD gets worse during, during the perinatal state, et cetera. It's always okay to get kind of like a full workup from your doctor. It's always okay to make sure that you're focusing on exercise and things like that. But what I think is most important is talking to a psychiatrist that understands. So if you're coming to them and saying, hey, I got this lab study and it shows this and stuff like that, that's who I always refer people to go to. But yeah, I mean, I think that the more exciting research that comes out and the more that we learn about the brain, the better. But I will say on kind of like a clinical stance, the reason I think it's important sometimes, even if you don't want to know the nitty gritty about it, is to understand that it's a brain disorder. I think it helps with shame. I think sometimes people think this is a disorder you can just stop thinking, or people are like, why are you being so weak? And when you understand that we'd never have that outlook or that opinion to somebody that's not walking because they lost the use of our legs, you shouldn't have that same opinion about somebody with mental health. So I think that's important to kind of remember as well.
Absolutely. Next question is, should one avoid more difficult forms of ERP if they aren't ready for it, despite having been in a debilitating state that requires treatment?
Yeah, the thing is when people say doing ERP, so this is my little soapbox. I think sometimes when people say ERP doesn't work for me, I want to internally explode, because I think that there's ways to do ERP where it always works. You want to work with a clinician that's able to kind of tailor it to you. So what I mean by that is, if I'm working with a client, let's say they have their OCD is all around pedophilia, so pedophilia OCD. It doesn't need to necessarily mean that every session the person is leaving just feeling wrecked and overwhelmed. I'm going to meet the client where they're at. So a lot of times I'll ask, the first question I ask is, how is this form of OCD for you personally limiting your life? And if they tell me, you know what, my siblings have beautiful nieces and nephews for me, and I want to babysit them, and I want to hold them, and I want to be there for their life. Family's important to me, but I'm not because of OCD. That's what the treatment's going to be all about. We're going to create a hierarchy around how do we get you back involved with your nieces and nephews, because that's a big value for you. Will at times it be difficult? Sure. The first time you hug your niece for the first time after years of avoidance is going to be terribly hard. But in life, is it worth it to challenge ourselves and to go through difficult things? Of course. Being able to hug your nieces and nephews should always override the OCD. And I tell clients, get mad at the OCD, at what it's taking. So when you talk about really hard ERP, what I'd say is it's also supposed to be done systematically. So by the time you get to those more difficult things, you have so much insight, you have so much evidence that the treatment works, you're getting your life back, you're motivated, you're having a good understanding of how the disorder works. And what I typically find with clients is, by the time we get to their harder things, it's been so lowered and not as difficult because of all the work they've previously done in sessions.
Yeah, I'll channel Alec Pollard. I'm like, ooh, I'm getting stuck for a second, right? That like small E and big RP is always more important than a big E and small RP. So if you're going to do a high level exposure, but you're not willing to commit to not doing rituals, we don't want you to do that first, right? We want you to do exposures that you're willing to do all the way, right? So that you can really see the benefit, because you're not going to see a benefit from like, oh, I did this big contamination exposure, but then I washed my hands. We still reinforce the cycle. We're only going to see the benefit from the exposures we do all the way, so no hand washing. What's important, though, I do want to caveat, is that I do think sometimes we send the message that like, don't overdo it, and like we like fragilize exposures or fragilize like ourselves and our ability to do hard things. And I want to channel Kim Quinlan here, right? That like today is a perfect day, right? But like we can do hard things. And it's really important to recognize that, is that exposures are meant to be hard and you can do it. Exposures are meant to be anxiety provoking, and anxiety isn't dangerous. And so I'm sending that message because I do think sometimes then some people hear like, oh, like if it's going to be challenging, I shouldn't do it. Or if this is going to be triggering, like, no, ERP is triggering. ERP is hard and it works and you can do it, right? Again, anxiety isn't dangerous. If we send ourselves the message like, can't do that, it's too hard, we're actually sending the message that anxiety is dangerous, we should be scared of it, and that we have to kind of tiptoe around it.
Absolutely.
Next question is, my therapist told me to do anti-OCD as ERP, but I don't want to because it feels morally wrong to my compulsion. Do I have to do that? Love this question. Or can I, maybe we should do a whole talk on this. Do you have to, right? We actually did, Chris, right? Chris can talk about our other talk for IOCD up and how it is on this. Can I just do ERP to recover by not doing my rituals, but not go as far as anti-OCD?
So what I'm going to take when I read this question was anti-OCD. They mean like overcorrection, right? Like pushing themselves further than normal.
Yeah. So I think the question is like, if like, let's go into like, if I'm afraid of blasphemy and I do a lot of rituals to be sure I haven't done it, do I have to commit blasphemy to overcome my OCD, right? So like if there's a conflict of being anti-OCD, like conflicts with my values, do I have to go that far? Do I have to do that?
So yeah, so Liz and I, along with two amazing other clinicians, did a whole talk on this. So please, if you're thinking about going to the November virtual conference, it's the weekend of the 4th. Please watch our talk. Like, do you have to, really take it to anti-OCD? To answer this question, if something is ever against your values, and we got to know the difference, right? Is it against the OCD or our values? But if something is really against our values, you don't have to do it. So for instance, if I'm working with a client that has scrupulosity, I'm not asking them, especially if it's against their values, I'm not asking them to sit there and to curse God and to spend all this time talking about how horrible God is. Because if that person is just feeling absolute sadness and they're crying and it has nothing to do with anxiety, but it really goes against their values, they really value the church and their faith. Once again, it has to be something that the client's willing to do. I can say in retrospect, I never felt pushed against any of my values. I never felt like I was doing something that I wasn't proud of in treatment. And all these years later, I can look back and there was nothing that ever was a red flag for me. So we want to find that balance. We, just like Liz was saying previously, we want to make sure that you're pushing yourself. Treatment is going to be difficult. So for instance, when you say just doing response prevention is great, but you got to still put yourself in the situation. So if it's tough or it's hard, yes, we want to do that. But if it's really going against your values, then no, we don't need to do that. So that's really what our talk was about. And what we all kind of came to the conclusion is that the treatment should not be like fear factor. It should be something your therapist is willing to do, that you're willing to do, and you'd be fine doing in front of people. So for instance, if somebody has contamination, yes, throwing away something in the dumpster makes sense. Picking something you dropped off the floor makes sense. But cupping like toilet water from a public restroom and like sipping it or splashing it on your face, I mean, that's ludicrous. I wouldn't do it. I'll tell you that right now. The most of the public wouldn't do it. I don't even think it's probably very safe. So when things become like that, it doesn't need to be done by that. So when we talk about the term, I haven't heard anti-OCD as much. I've heard the term overcorrection. I do believe that sometimes we want to push ourselves. If we push the exposure and treatment here, everyday life doesn't become as hard. But once again, what you're doing to push yourself should absolutely be something that you feel is in line with your values. So I think that's really where the balance needs to be is, are you resisting compulsions? Is there response prevention? The other thing I always remind clients is the whole point of treatment is to learn that OCD lies to you, that OCD kind of takes all of your fears and creates this whole big OCD story that it wants you to buy into. It wants you to have yourself feel small and feeble so you can't do anything and fight against it. So that's why it's important to recognize that you can't learn if the treatment's like fear factor, and you can't learn if it's against your values because you're going to question going to that therapist. So in conclusion, what I'll say is making sure that you're pushing yourself. Treatment should still be tough and challenging, like Liz said, but it should never be something that you walk away from that session and you feel you at your core is feeling shame, embarrassment, or really just disgust from what you and the therapist did.
Exposures should align with our values, not go against them. So doing an exposure should bring us closer to our values and how we want to live our life and what we want to be doing, not further away. Now, I'm going to get questions about this because people are going to say, but OCD makes me think that doing this exposure directly conflicts with my values, right? That I want us to take OCD away, right? If you didn't have OCD, what would you be doing? Right? It would be more important to get contaminated with my daughter, but us spend time together than for me to live in this surgical zone in my house. Right. And so it might feel like, oh, but OCD is keeping her safe. It's like, well, that's an OCD value, right? That's OCD telling you the values. But my real value is I want to be present and I don't want to be taken away from life with her. But again, if you're being asked to do things that you're like, OCD or not, I wouldn't do that, then you shouldn't be doing it. And that's not the goal of treatment. And it doesn't have to go that far. Lauren Wadsworth has done some incredible talks on this. It was the plenary at the conference this year where we talked a lot actually about how do we make sure that exposures that we're doing are both values and also justice-based as well. And there's great articles on this. And we did a webinar with her that I highly recommend checking out. Because the old school ERP tended to be more just like, oh, this is how you do it. This is how we treat it versus like, what aligns with your values on that? What makes sense? Next question. Sometimes I get confused about the difference with distracting myself and engaging in normal life once I've completed an exposure. Love this question. I get this all the time. Liz, what's the difference between distraction and engagement, right? How can I tell the difference? For instance, after I do an exposure, do I just need to sit there? Do I just need to wait? Or can I go call a friend?
Yeah. So what I always try to do, and this has been my motto since I became a clinician, and I love getting out of the office. I love, clients bringing stuff in, is I want to try to recreate what your life would look like outside of OCD as much as possible. So maybe in the beginning, we might do an exposure and kind of have somebody sit there, but ultimately the bigger answer is, no, that doesn't make sense, right? For a client to do an exposure and then just sit at a wall. That wouldn't be what you're doing in life. So what I ask the client is, what would you be doing if you didn't have OCD? And they're like, well, my friends and I like to skateboard. We like to do this. We like to do that. Okay. What I want you to do is I want you to do the exposure. I don't want you to run out with your friends and immediately skateboard. What I'd like you to do is do that exposure, kind of sit with that anxiety, really learn from the exposure, push yourself, see the value in it. And once you're kind of at a point where all of that happened, do it a few more times. And then once you've done it enough, go skateboard with your friends, but bring that anxiety with you. It's not, okay, I'm running from the anxiety, what I just did. I need to go to my friends and distract. No, it's showing yourself like, I can have OCD, I can be triggered, I can have intrusive thoughts, and I can have the urge to do compulsions and function. And that's what probably for Liz and I, when we first, entered real life,
Chris, you froze. Okay, I'm going to pick up where Chris left off. So I think what Chris is really saying and talking about is what is the function of the behavior? If the function is like, hey, I've addressed my OCD, I did my exposure, and I'm moving on, great. But if the function is I've addressed my OCD, but I don't want to keep thinking about it, and so I'm going to do this activity to distract myself from my OCD or my fear, then it's not helpful. Right. And so exposures are about doing an exposure, allowing the distress to be there and moving on. So again, I want you to think about what is the function of the behavior. If skateboarding with my friends is because like I've done the exposure, I want to go skateboard, great. But if it's I did the exposure, but I don't want to keep thinking about it and I need to go skateboard to distract myself, then we're not leaning all the way into the exposure and the behavior is being used to suppress OCD. So again, is the behavior because I want to engage in life, or is the behavior because I want to distract, or I want to not feel, or I want to not sit with this exposure? Are we running from it? Are we trying to avoid the feelings of distress?
Yeah, well said.
I tried to pick up right where you left off when
no,
you froze.
You did, because I could hear, but it was weird,
yeah. Okay, so next question is, how do I find resources in Spanish? My mom has OCD, and it's been hard for her, to engage in therapy and find somebody who speaks Spanish.
I think
wrong type. This is fun. We're freezing, and then we're not able to talk.
Yeah, no, what I was going to say is I do note that the IOCDF, there's a lot of resources, right? The IOCDF has I can never say it properly, so I'm not going to butcher it in my white boy accent. But the conference, there's actually a whole conference done in Spanish each year. So definitely that's important.
And it's called Trastorno Obsesivo Compulsivo. And so this is OCD, right? How we say OCD in Spanish, but we do an entire Spanish. We have an entire Spanish webpage, right?
We have a lot of resources on the IOCDF.
Can you post that, if you don't mind, Skyla, just the website and the webpage that's in Spanish, but then we have an entire conference. We have advocates, lots of groups. In addition, when you are searching for help, you can look for clinicians that speak Spanish. I can tell you, we have Spanish-speaking clinician at our clinic. A lot of clinics do. I know Katia Moritz does a lot in Spanish. And so like lots of different clinics have a lot of Spanish resources that are available. Feel free to reach out and let me know where you're from, and we will try to help navigate that for you better as well. Let's jump into the last question that's live because it's already 11:55. Well, the last 3 questions. So the first one at 11:54, what advice do you have for people who were treated with unhealthy exposures? When I say unhealthy, I'm saying it in generally, like physically and emotionally.
Yeah, so the way I'm interpreting this question is somebody who went to a therapist and they were doing ERP incorrectly. So maybe it felt like fear factor, maybe it felt like something you walked away from and didn't feel great. I think what would be really important is finding a different clinician, because remember, if you go to a restaurant and get food poisoning, you wouldn't stop eating forever, right? You'd go to a different restaurant or you confront the restaurant. So if you're working with a clinician who's currently doing it, I would have a conversation with them. But let's say that you're no longer, but you're a little hesitant about going back into treatment. Bring that to the first session. Sit down with a therapist and say, I really want to get back into treatment, but my last provider had me do unhealthy exposures that it sounds like physically, emotionally just was not a great experience. I think sometimes new therapists get very eager and they want you to get better. So they're just throwing things at you and it's going too quickly. So I would say have that conversation with the new therapist and let them know, so that the therapist can go at a pace that you're comfortable with. Lastly, what I'll say is anytime I'm about to do exposure with a client, the first thing I do is we talk about it, we kind of process it, and I make sure that they're on board. So definitely make sure to do that.
Absolutely. I am going to add in the link right here for that values and justice-based ERP webinar. So Skyla will post that and you will see that because I know somebody, Betsy, you asked. So you'll see that at the bottom for anyone who wants to click on it. Last 2 questions is the thought that the fear and discomfort will get easier with time / is fear and discomfort necessary for ERP? Sometimes I don't feel much discomfort when I'm engaging in an exposure. We should feel discomfort if we're engaging in exposures with response prevention at the beginning. But the goal is that as you do it and approach it, the discomfort and fear should go away. Triggers should be thoughts, not triggers. They're triggers when our OCD is attached to them. But actually, if we unattach OCD, we shouldn't still feel the same anxiety and discomfort. If you're doing it early on and you're not feeling any discomfort, I might ask a few questions like, are you holding on to anything? Are you ritualizing to make yourself feel better? If not, what we know is that anticipatory anxiety is typically worse than the actual exposure. And so it also makes sense that sometimes we think things are going to be super challenging, super anxiety provoking, and we're relieved or surprised in different ways when we jump into it. And then Chris, there was a question about appearance. Why do I feel happy with my appearance one day and then hideous the next? And I know we have a BDD webinar, I think, coming up soon. So let's talk about both.
Yeah, definitely. Make sure, the BDD special interest group, we're coming up with some good stuff. So be on the lookout for that. There's going to be resources. But what I would say to answer that is because it's not about your appearance. It's not about your appearance. And everybody with BDD experiences that all the time. They'll have those moments that they actually like how they look. They'll feel on top of the world. It's like winning the lottery. And then they can literally 5 minutes later look in a different mirror, different lighting, sometimes the same mirror, same lighting, and hate what you see. And that's because it's a mental health disorder. I think that's what makes BDD different than OCD, is a lot of people still believe that it's something to do with their appearance. So we can't trust our assessment of how we look before real good BDD treatment. That's part of what comes at the end. And then you more consistently see yourself. So that's why, Kylie, you got to get in some treatment, because the thing about it is that's what's going to happen to you consistently, is you're going to find yourself sometimes liking, sometimes not, and chase that feeling of liking it. It's a mental health disorder. And it has nothing to do with your looks, and it has everything to do. There's actually evidence, and there's a lot of research on the BDD webpage from Jamie Fusner out of UCLA and others that talk about what happens when we see ourselves in the mirror and why we see ourselves differently compared to other people. A lot of times it's also impacted if you're tired, if you're hungry, if you're stressed, if you're triggered. So there's all these reasons that we actually see ourselves different, and it has nothing to do with your appearance. Your appearance doesn't change. What you see in the mirror does.
But BDD treatment can help you be more confident and have a better understanding of all of that, just like ERP treatment can for OCD. Thank you all so much for joining. I love our Lunch and Learns. Next week, I cannot believe we're in the second week of October, is OCD week. So please make sure you check out iocdf.org/peace of mind to learn all about the events happening next week, OCD SoCal, So many different affiliates are doing incredible events themselves as well. So get connected, join the community. You will see a lot of us and a lot of others next week. I know, Chris, I'm excited for our Lunch and Learn next Wednesday, which is going to be with both Tom Smalley and also with Kevin Anderson, where we're going to focus on anxiety in athletes, OCD in athletes, what it's like, stigma, etc. So lots of fun stuff. Be sure to check out our schedule, iocdf.org/OCD week. And then, of course, we'll be back for regular programming soon. Couple of updates. We are going to meet next week for OCD week, but the following Tuesday is going to be replaced with the research.
Wednesday.
Sorry.
No, it's all good.
You know what I mean. Following Wednesday will be the research roundtable. So typically the research roundtable is the second Wednesday of every month, but since next Wednesday is the second Wednesday is OCD week, we're going to do a lunch live webinar instead, and research roundtable will be the third Wednesday this month. Then we'll be back the fourth. So anyways, lots of moving parts. Thank you all. As always, help and hope are always available. Chris, I'll give it to you.
I just want to as always, thank you everybody for watching this live, asking your questions. We hope that we gave you some hope and some information. Stay tuned with us. We'll be here every Wednesday at 9 a.m. Pacific Standard Time. There'll be a live stream. Come hang with us each Wednesday. Thank you.
Bye, guys.